to introduce Dr. Hoda Abdel Magid, who is currently a postdoctoral research fellow at Stanford's Department of Epidemiology and Population Health, as well as at the Center for Population Health Sciences. She's also a fellow in the Big Data Scientist Training Enhancement Program at the Palo Alto VA. And she did her master's in environmental epidemiology from that school in Baltimore in 2015, and her doctorate in epi from the University of California, Berkeley in 2018, with a focus there in social epidemiology. Her research in graduate school was really doing novel, important work, focusing on new and emerging tobacco products and their use among adolescents and young adults. And her current research aims to further understand chronic disease behavioral risk factors, including risk factors for cancer and cardiovascular disease, and leverages spatial epidemiology to examine health disparities among socially marginalized communities, that we'll be hearing about today. With that, I'd like to go ahead and let her begin her talk. And what we'd ask is that you hold questions until the end of the talk, when we will have a Q&A period. If you want to put questions into the chat along the way, that's fine, but we're going to really address those at the end of her talk. So thank you. Hoda?
Awesome. Well, thank you so much, Lisa, for the introduction. And hello, everyone. Thank you for joining today. My name is Hoda Abdel Magid, and I'm a postdoctoral fellow in the Department of Epidemiology and Population Health at Stanford. I'm also a fellow at VA Palo Alto, as Lisa mentioned. I'm excited to share my work today, focused on leveraging spatial epidemiology to reduce health disparities. So my goal today is to share my approach for health disparities research and the potential value it can provide for different areas of epidemiology. To start, I will give a brief summary of how my academic journey has shaped the way I think about social determinants of health. Then I will walk through a framework for health disparities research that accounts for the multi-level physical and social influences of disparities. Next, I will share some of the methods I have used to disentangle multi-level disparities. Specifically, I will demonstrate the utility of cross-classified multi-level models for health disparities research using selected results from my work. And to close, I will share what drives my commitment to this work and how I further this commitment by engaging in epi spaces that foster diverse collaborations and forward our research for reducing health disparities. So all of my work is based on the premise that to comprehensively understand disparities, we are required to simultaneously account for both the physical and the social characteristics of environments. This approach has been shaped by my academic journey. My academic journey began unconventionally as a community college student. I then moved to an undergraduate Jesuit institution whose social justice-focused pedagogy, designed for educating the whole person, significantly shaped the way I think about health disparities. Their unique undergraduate public health curriculum taught me early on that social determinants of health are key drivers of population health, and that disparities in social determinants of health are key drivers of population health disparities. My training continued at Hopkins in environmental epi. At this time, I was also hired at the Institute for Global Tobacco Control, where my work on tobacco use and cardiovascular health disparities was recognized by the American Heart Association, which awarded me one of 9 national graduate public health fellowships. This period of my training refined my research goal to account for how the physical determinants of spaces shape health disparities. In the interest of time today, I direct you to my list of publications, but briefly note that at this time of my training, I worked on several studies examining disparities in secondhand smoke exposure levels among diverse domestic and international cohorts. My doctoral training in social epidemiology at Berkeley further refined my approach to health disparities research. At this time, I wrote and was awarded my first NIH grant, a 2-year predoctoral NCI supplement, which was funded under a parent grant at Stanford and UCSF. This funding allowed me to leverage the existing data and resources of the parent grant, and to also gain experience using spatial epi methods. Building off of my previous work at Hopkins, I shifted to an emerging area of research in the tobacco control world and focused on alternative tobacco products like e-cigarettes, hookahs, and Juuls. And I will highlight some of that work today. This period of my training refined my research goal to now account for how the social determinants of places shape health disparities. I continued my training across the pond, now at Stanford and the VA, where my research is focused on spatial epi. My training in spatial epi has led me to understand that both the physical and the social determinants of spaces and places together shape health disparities. More often than not, traditional disparities research examines physical or social determinants of health, but not both. For example, studying only the effects of a neighborhood's socioeconomic status on tobacco use disparities neglects the effects of the neighborhood's tobacco retailer environment on tobacco use disparities, and vice versa. The framework that informs my research defines social determinants of health as both the physical and the social characteristics of environments, and examined together at the same time. With the example of tobacco use disparities, we would need to simultaneously examine a neighborhood's socioeconomic and structural influences on tobacco use disparities and the levels that these influences operate in. This is important because it recognizes that the mechanisms producing disparities are complex, and in order to comprehensively identify and reduce disparities, we need to holistically study both the physical and the social determinants. Again, that is to say that both physical and social determinants of spaces and places together shape disparities. I apply this framework to all of my research on health disparities. Before I share some of my work on health disparities, I want to take a moment to recommend that for anyone who has the opportunity to access or is thinking about accessing VA data, please take advantage of that opportunity because it really is a treasure trove. I have used VA data to examine several health outcomes, two of which I will highlight today, namely COVID and telehealth, to demonstrate my approach to social determinants of health, motivate the role of social determinants of health as primary drivers of population health, and the importance of thinking about disparities very carefully. For the first outcome, in 3 published manuscripts, VA colleagues and I demonstrated disparities in COVID outcomes by physical and social determinants. Our analytic population consisted of 6 million actively enrolled patients in VA healthcare. We then examined the likelihood of obtaining a COVID test and testing positive for COVID by patient demographics, while controlling for patient comorbidities, VA facility characteristics, and county level social determinants of health. And we followed for VA administered tests from February 8th, which was the earliest recorded test at the VA, through June 23rd of 2020. We found that although the VA is testing more disenfranchised patient groups than other healthcare systems, COVID disparities still remain. These included differences by rurality and region. For example, our data showed that among those tested for COVID, rural veterans were underrepresented. Rural veterans were also underrepresented among those who tested positive for COVID, which may reflect the patterns of where COVID was prevalent at the time we conducted this analysis. We also found differences by race and ethnicity. For example, Black veterans were 23% more likely to test positive for COVID than white veterans, and Hispanic veterans had a 43% higher risk of COVID than non-Hispanic veterans. I later expanded this work to further examine COVID disparities in the VA by geography and time in a paper that has been recently published. I used veterans' home zip code to geographically link county level data from publicly available area-based socioeconomic measures shown here as proxies of veterans' county level social determinants of health. Given our limited time together today, I direct you to these published manuscripts in both IJERPH and scientific reports. Both these papers further demonstrate evidence of COVID disparities by both physical and social determinants at the VA over the course of the pandemic. Ultimately, we found that although financial barriers to care are lowered at VA, veterans are not immune to the negative impact of the social determinants of health that they face outside of VA. These results suggest that other factors, such as external social inequalities, are driving disparities in COVID among veterans. This work was also featured in a VA brief focusing on advancing healthcare for our veterans. Directly related to COVID disparities, the second outcome I examine at the VA is telehealth, where I also demonstrated the importance of a comprehensive approach to social determinants of health. I worked with colleagues at the VA Center for Multiple Sclerosis, including several clinical neurologists and neuroepidemiologists. Using 20 years of data from the VA on telehealth encounters among neurology patients across all VA sites, I examined trends of telemedicine utilization among MS patients and their matched controls in a nested case control study. This study is currently under review at JAMA Neurology. I first described differences in telehealth utilization among cases and controls, including differences by telehealth format and care type, where telemedicine varied by care type, including phone, video, and care specialty. I then turned to identify the physical and social influences on these patterns. I demonstrated differences in telehealth utilization by multi-level physical and social determinants. I look forward to sharing a published version soon. But overall, my studies at the VA are a clear manifestation of my approach to examining social determinants of health and their role as primary drivers of population health. Because even in an integrated healthcare system like the VA, where exposure to many adverse social determinants of health are lowered, veterans are not immune to the social determinants of health that they face outside of the VA. And ultimately, this shows us just how important it is to carefully think about health disparities. So in the second section, I will walk through a framework for health disparities research. I carefully think about health disparities research in three parts. First, I think about how we distinguish between different levels of disparities research and what constitutes a disparity. Second, I think carefully about how we can comprehensively identify both the physical and the social influences of health disparities. And third, I think carefully about how we can disentangle these influences across multiple levels. You may have seen this article in Stat News about health disparities research. I think this is a thought-provoking piece, and I highly recommend it for anyone who hasn't read it. What this article highlights is how intentional we have to be when accounting for the comprehensive mechanisms operating to produce disparities. For example, most work intended to examine health disparities is actually work on health differences or inequalities, and less on true inequities and disparities. So the first way in which I carefully think about disparities is by distinguishing between levels of disparities research, including differences, inequalities, inequities, and disparities. For example, this conceptual framework that I'm currently working on aims to distinguish between the levels of disparities research and illustrates their relationships, and to drive home the point that health disparities research requires two things. One, a fundamental understanding of what these terms are and what they are not. And two, rigorous methods specific for research at these levels. The goal of this conceptual framework is not to focus on semantics in health disparity definitions, but to emphasize the importance of understanding the link between ethical perspectives and the choice of quantitative disparity measures. That is to say, to emphasize an intentional and careful approach to the disparity measures we use and how we use them, because they have significant implications for population health. The second way in which I think about disparities is by thinking about how we can comprehensively identify both the physical and the social influences of disparities. One example of this is my work on hypertension. Hypertension places a major burden on the American population, affecting around 1 in 2 American adults, but disproportionately affecting racial and ethnic minorities. Incidence rates for hypertension are around 10 to 30% higher among Black Americans than all other racial ethnic groups. The physical and social determinants of hypertension have been repeatedly examined, but there is less research examining the combined effects of physical and social determinants of hypertension disparities. This is an area of research I am passionate about because I think it has significant potential to make long-lasting impact on population health and health disparities research in general. One project in which I demonstrate this commitment is my work using spatial epi to reduce hypertension disparities. For this work, I currently receive funding from NIH's Loan Repayment Program, specifically the Health Disparities Research Award from NHLBI. This award provides financial support for my research, including larger grants on hypertension disparities that are currently under review. And I just want to take a quick moment to plug this program. I highly recommend applying for the LRP for anyone who's interested. as it provides researchers a great platform to submit preliminary proposals for evaluation by NIH reviewers, practice their grantsmanship, and receive feedback for larger proposals. One of those larger proposals informed by my LRP application is my K99R00, which is currently under review at NHLBI. In this grant, I aim to examine the underlying pathways connecting race and hypertension. Specifically, I examine the impact of spatial social polarization, or SSP, on hypertension disparities. SSP is the process by which a population within an area diverges across socioeconomic characteristics, resulting in disparities. And SSP indices measure the extent to which a population is distributed at extremes of privilege and deprivation. For example, income SSP measures the extent to which an area's population diverges into very high and very low income earners, with fewer income earners in the middle. I examine SSP along 8 domains, including established socioeconomic domains like race and ethnicity, and novel structural domains that I have proposed, including housing. The central hypothesis is that living in areas with high SSP increases hypertension disparities. This proposal is based on key theoretical frameworks of space and place, including the nested conceptualizations of the link between spaces and places on health. In this conceptual framework shown here, the social construct of race operates in feedback through polarization distributions to produce hypertension disparities. And geographic areas have features that affect hypertension disparities along both socioeconomic and structural domains. Each of these domains can produce disparities in the psychosocial and material conditions under which individuals live, potentially determining their risk for hypertension, and subsequently producing hypertension disparities. This project simultaneously leverages several linked data sources, including spatial, cohort, and claims data. This includes data from 2 cohorts, including the cardiovascular health study and the REGARD study, as well as spatial data from the RECEIVED study, which is led by Gina Lavasi at Drexel, and private and public data from Optum, as well as a 20% sample of Medicare that I have access to and have used for other work currently under review. And the third way in which I think carefully about disparities is disentangling disparities at multiple levels. And by this, I mean parsing out the contributions each exposure level has on an outcome. I demonstrated this work for several outcomes among adolescents and young adults. I focus on adolescents and young adults because they are a vulnerable risk group and their development at this time occurs in a sensitive period in their lives. This is when health behaviors are forming and are tracking into adulthood. And 2, their primary health exposures at this time occur at 3 levels: individual, school, and neighborhood. And 3, at each of these levels, we see physical and social influences that operate together to produce disparities. Because of these 3 reasons, examining both physical and social determinants of adolescents and young adults' health significantly informs health disparities research. I will briefly walk through some examples of research I have done examining both physical and social determinants among adolescents and young adults. I'll use these studies to demonstrate how traditional methods were not sufficient to disentangle multi-level disparities, then present an advantageous method that accounts for the data structure, and conclude with the results. As I mentioned earlier, during my doctoral training, I shifted from examining secondhand smoke exposure to examining alternative tobacco products, or ATPs. ATPs pose a threat to decades of public health campaigns aimed at reducing tobacco use because they re-normalize smoking. They do this by increasing benefit perceptions and decreasing risk perceptions of tobacco products. I examined the impact of physical and social determinants of adolescents and young adults' ATP use. Because of the unique funding mechanism that I was awarded, I was lucky to have and use the interdisciplinary resources of 3 institutions at my disposal to complete this work: at UCSF, at Berkeley, and at Stanford. One of those resources was access to the Perceptions Project, which was led by Dr. Bonnie Halpern-Felcher at Stanford. The objective of this project was to examine the role of risk and benefit perceptions in tobacco product usage among adolescents. I used data from the survey of adolescents in 9th and 12th grades who were recruited from 10 California high schools with diverse student populations in 4 waves from 2014 to 2018. I produced several research outcomes, with the first being my first author publication in JAMA Network Open. In this study, I demonstrate adolescents who report ownership of ATP promotional materials were more than twice as likely to have initiated ATP use 1 year later. These findings have been used to inform FDA's regulation of e-cigarettes and are significant given that right now the FDA is not regulating manufacturers who have not put in an application to market e-cigarettes. Then I turn to examine the impact of environmental exposures on ATP use. I examined the association between tobacco retailer density and proximity with ATP use using 3 levels of nesting. I started with individual level longitudinal data from the perception study. Then I geocoded participants' home addresses and addresses of tobacco retailers using purchase data from the California Board of Equalization. I linked these data to area-based socioeconomic measures from ACS to characterize adolescents' home neighborhoods. And using participants' school locations and data from the California Department of Education, I further characterized participants' school neighborhoods. These levels are important because they can influence ATP use through multiple pathways, including policies, normative behaviors, and access to resources. As you can imagine, with all of this data, this was a really exciting study for me. It is definitely one of my favorites. I felt like I was a kid in a candy store of data the whole time. But of course, this didn't come without its challenges. I had initially thought I would need to use traditional multi-level models, but as I was cleaning and mapping the data, I realized I need to check my assumptions. I had assumed my data was completely hierarchically nested and didn't at first consider the possibility of cross-classification. But while working at the Stanford Geospatial Center and using GIS, I found evidence of impartial nesting. This map illustrates an example of the cross-classification I found for 2 of the high schools in the sample. The map shows that some students living in the same census tracts attended different schools. This is evidence of cross-classification. It illustrates the importance of accounting for partial, non-hierarchical nesting in our multi-level modeling. So traditional multi-level models that I was originally going to use were no longer enough. I needed a method that accounts for the impartial nesting and can disentangle the multi-level effects of the physical and social influences on these ATP disparities. This led me to cross-classified multi-level models, which are an advantageous tool for health disparities research because they outperform traditional multi-levels by accounting for non-hierarchical nesting. They also allow us to quantify the contribution of each contextual level. The models estimate the relative variance contribution or the random effects of each level and allow us to evaluate the extent to which fixed effects in each level explain the observed variation in our outcome. I use this strength of cross-classified models when examining multi-level influences of screen time among adolescents using AdHealth data in this paper published in Preventative Medicine. My objective was to parse and quantify the relative contribution of each level on adolescent screen time. I used data from AdHealth Wave 1 when participants are adolescents, as well as data from Wave 4 when they are young adults. I classified screen time continuously as self-reported hours per week of television, videos, or computer game activity at baseline, and categorical as extended screen time, more or equal to 14 hours per week, which is based on AAP recommendations. I estimated random effects from null cross-classified models predicting screen time in Wave 1 and Wave 4 of AdHealth. These include hierarchical school-only and neighborhood-only models, as well as the null cross-classified models with both school and neighborhood characteristics. The results of these models accounting for both school and neighborhood allowed me to estimate the between-level variation in screen time and the contributions from each level. This also shows the third major strength of cross-classified models. These models allow for targeted interventions and policies in the levels yielding the most impact. I demonstrate this third strength of these models when evaluating hypertension risk among adolescents and young adults. For example, traditional multi-level models of hypertension risk can overestimate the importance of each level and could ultimately lead to targeting interventions or policies in less impactful levels. And while there is a lot of research showing neighborhoods influence hypertension risk in adults, there is less research showing if this is true for adolescents and young adults. In this paper, I evaluated which context, schools or neighborhoods, matter more for adolescents and young adults' hypertension risk. This would not have been possible without cross-classified multi-level models. So now that the advantages of these models for disentangling multi-level disparities have been demonstrated, I will briefly walk us through a cross-classified multi-level model formula that can be applied to multiple outcomes and then show the results of these models in the studies I mentioned. Now, first off, I want to apologize for the use of Greek letters and a long model on a Tuesday afternoon over Zoom, but I will be brief. In fitting this cross-classified multi-level model example, we ultimately are modeling the outcome, Yijk, which is the outcome for a person denoted I, nested in school denoted J, and neighborhood denoted K. Please note that this is only the outcome if we are assuming Y is normally distributed and we are modeling the mean. In the binary case, we would be modeling logit Yijk, but for simplicity, I present the stylistic equation shown here. Okay, so this is the outcome. This outcome is a function of the following terms, starting with our intercept, alpha. I've always loved the language here. It's called the grand mean. Alpha is the grand mean of the outcome across all three contexts, but holding all covariates constant. This is also followed by an individual level coefficient with a vector of individual level covariates. An example for my work is adjusting for parent level SES. This includes similar coefficients at the school level with respective school level covariates, such as a school's SES. In my studies, I, for example, use proportion of students in the school receiving public assistance subsidies. And then for our third level, the neighborhood level, we have a neighborhood level coefficient with covariates such as neighborhood level SES. Lastly, this is followed by random effects for each of the levels in our study, the school, neighborhood, and individual levels. All are normally distributed with a mean of 0 and their corresponding variances. And so these are all of the terms in the model: 3 levels, fixed effects, random effects and their distributions. Note here that the parentheses around IJK are very intentional. The parentheses are written this way to indicate the cross-classification, because unlike a traditional multi-level model, it isn't just IJK, i.e. full nesting, but it's the outcome I for an individual in a given neighborhood and school. Okay, so now that we are all experts in these models, I will highlight some results from my work using these models. In this example, looking at the association between tobacco retailer density and proximity with adolescents' use of alternative tobacco products, I hypothesized that adolescents living in neighborhoods with greater tobacco retailer density and proximity have a higher risk of starting to use alternative tobacco products. Again, it is important to note that while this pathway is very well understood for cigarettes, it is very unclear for new tobacco products. In this study, I found that students living in neighborhoods with greater tobacco retailers per square mile had a higher odds of ATP use. Overall, I demonstrated that the spatial patterning of tobacco retailers clustered in adolescents' home neighborhoods may influence their alternative tobacco product use. I showed that the tobacco retailer environment in the home neighborhood may influence adolescents' ATP use more than the school neighborhood. That is to say that neighborhoods may matter more than schools for ATP use. These findings are being used by stakeholders such as the FDA to inform interventions in the tobacco retailer environment. And in recognition of this work, I was awarded the Society for Adolescent Health and Medicine, or SAM's, New Investigator Award. This project also led to more work in this area. For example, I was invited to collaborate on a position paper at SAM detailing 4 positions for protecting youth from the risks of e-cigarettes. In my next example, using cross-classified multi-level models, this time for screen time, I direct us to this figure published in Preventative Medicine. We can see that the results of the cross-classified multi-level model, accounting for both schools and neighborhoods, suggest that the between-level variation in screen time is driven almost exclusively by school-level variation. Without cross-classified multi-level models' ability to parse the contribution of each contextual level, I would not have been able to demonstrate that schools and individual level factors contribute more to youth screen time than neighborhood factors. That is to say that in this study, schools may matter more for screen time than neighborhoods. This study suggests that the transition from adolescence to young adulthood may be a period that sets sedentary behavior trajectories for the rest of adulthood, and thus represents an important window for early intervention in schools. This study also led to another research outcome on screen time among children and adolescents during the pandemic. This paper was published in Obesity in 2020, and as you can imagine, was frequently cited during this time of the pandemic. In this final example, using cross-classified multi-level models, I used wave 1 and wave 4 data from AdHealth and examined adolescents and young adults' hypertension risk using 4 outcomes: hypertension, systolic and diastolic blood pressure, and mean arterial pressure. Similar to my study on screen time, I also found that characteristics of adolescent schools are more strongly associated with hypertension risk in young adulthood than characteristics of their home neighborhoods. For example, at the school level, I found that having a higher proportion of non-white students was associated with higher hypertension risk into young adulthood 14 years later at follow-up. This suggests that something systemic is occurring. Specifically, this suggests that unequal conditions in school environments for non-white adolescents may increase the risk of hypertension later in life. And we have seen this with previous research showing that social determinants of health and disparities by race and ethnicity are rooted in structural racism, and that structural racism at the school level results in inequitable access to resources required for health and well-being, including uneven access to quality schools, better neighborhoods, and quality medical care. Without cross-classified multi-level models, we would not be able to identify the most impactful context for interventions of hypertension risk factors, which track from childhood into adulthood, and has one of the largest burdens in the population. So I have shown how cross-classified multi-level models can be applied to disentangle multi-level disparities for different health outcomes. While I used these models for evaluating physical and social determinants of disparities among adolescents and young adults, these methods can be extended to other vulnerable risk groups and other health disparities research. So this leads me to my research commitment, and I will close my presentation with this section. I am committed to developing and implementing rigorous methods like the cross-classified multi-level models I showed today, methods that are universally applicable for health disparities research. My goal is to develop a spatial epi framework that can account for the complexities of physical spaces and social places and how these complexities influence health disparities. I'm also passionate about teaching these methods in fundamental epi, social epi, and spatial epi courses because of the opportunities that they can provide future epidemiologists. My commitment to health disparities research is fundamentally rooted in my lived experience as a member of an underrepresented group in higher education and STEM. For example, I identify as a Muslim Egyptian American woman, and on the most recent census, I had to check white as my race, though this is not how I identify. I have almost always been the only member of my race and faith in many academic spaces. So it is precisely because of my lived experiences that I further my commitment by engaging in epi spaces that foster diverse collaborations and forward our research for reducing health disparities. One demonstration of this is through my engagement in the D&I committee at SCR. I first started out in the D&I committee as a member when it was led by Stephen Gilman and Nadia Abel-Azim, who invited me to the committee. In this role, I developed a workshop and 2 symposia for SCR members, including a workshop on police violence in October 2020, shown here. as well as a workshop in December 2020 on mentoring, where we discussed effective strategies for mentorship of graduate students, postdocs, and early career scholars from underrepresented backgrounds. And as part of the 2021 annual conference, our D&I committee put together several sessions shown here. One of which was a session we developed on lessons learned from D&I efforts in epi departments across the country. For this session, I was lucky to work with faculty from 5 universities, including Lisa. In recognition of my work on the D&I committee as a member, I was invited to co-chair the committee. On this current committee, I'm lucky to work with many amazing members at different stages of their careers, and to also work with former SER president, Jay Kaufman, and fellow co-chairs, David Lopez and Sue Bevan. We have been hard at work, and for the 22 conference coming up in Chicago in June, fingers crossed we are in person, I'll take a moment to shamelessly plug that our committee has another great lineup of sessions. These include sessions on housing and health featuring Kara Rudolph in the department, the future of epi practice through JEDI featuring incoming SER president Oni Ara from UCLA, and results of our SER D&I survey that was sent to all SER members in 2021. We are working on the paper analyzing these results as a committee, and we will be publishing it in AJE soon. Please join us for these sessions in June. Again, fingers crossed we will be in person. I'm also engaged in JEDI efforts in other academic spaces, including at the VA, NCI, and at Stanford at the department and university levels. In recognition of this commitment, I have been fortunate to receive Stanford's university-wide inaugural Postdoc JEDI Champion Award. So this concludes my presentation. I would like to thank principal collaborators and acknowledge the cohorts and funders that have supported my research. Thank you to Lisa and Charlie for inviting me, and Gerald for coordinating today's seminar. And thank you all for your time and attention. I look forward to your questions, learning more about your work, and to future collaborations.
Good afternoon, everybody. If you have any questions for Dr. Magid, please raise your hand, and we'll, or you can just ask your question directly.
Can you hear me?
Yes, we can hear you.
Oh, thank you. So thank you very much for a very interesting talk. That was a lot. You've done a lot of work. Very important. So I have one question for the model that you actually described. Are you worried at all about collinearity in those? Because yeah, you understood. Because a lot of it, when you're looking at schools and you're looking at individuals and you're looking at SES and looking, so sorry, it's just because my camera is a different place where I see. So that's my question. It may be that my unfamiliarity with this model, but that's the first question that I had. Some of yeah, why don't yeah.
Yeah, thank you so much. That's a great question. I've been thinking about that question a lot with these models. I think what's really important with these models is the approach to model fitting. It's really important that we not disregard the multi-level models. And so the general approach for fitting these models is to fit multi-level models with and without the cross classification at each level, and to also fit models at each combination. So for each combination, for example, fitting a null school and neighborhood model, and then also fitting the multi-level version of that and the cross classification version of that, comparing the random effects and the fixed effects. And I think most importantly is that we adjust for covariates that have been a priori defined at each of the levels, informed by the prior literature.
And are you able to see, for example, to see whether one step over and above adds something, or whether it skews? Yeah, you don't.
Yeah. And I'm happy to show results from in detail on that. But yeah, these models can take quite a long time to fit, but it's important to do it step by step for sure.
Thank you.
Austin?
For a really great presentation. Can you hear me? Okay, perfect. My question is about spatial dependence within cross-classified models. So I've never really, my sense for cross-classified models still are kind of mainly in the education literature and less so applied to public health. And so I'm just less familiar with seeing them applied with public health examples. But I'm curious to hear your thoughts on, potential spatial dependence of the units you're using for both the school and the neighborhood level, particularly for the neighborhood level. Then my second question is related. What are your thoughts on the unit you've used in your research? It sounds like it's kind of what was available, but I'm just curious to hear your thoughts on other units that may be relevant or the direction of your future research in terms of kind of both the modeling approach, but also the conceptualization of how we define a neighborhood.
Great questions. It's nice to meet you. Yeah, so for the first question on dependence, I think it's really important. I mean, I've seen a lot of research on geographically weighted regression in this context, and to my knowledge, I don't think that these models outperform the cross classification in this case. That is to say that I don't think the independence needs to be the dependence needs to be accounted for any more beyond the cross classification. But that's just based on the examples that I've seen. There could be more literature in this area, and I'd be curious to read through it. And then with regards to your second question about the aerial unit of choice, this is something that I'm really interested in. And so in the K that I proposed to look at a whole slew of spatial levels, but mostly to focus on sub-county data. And that's where my primary interest lies, because I think it's important to use these lower levels of spatial aggregation to help us disentangle disparities.
Thank you.
George?
Hi, Dr. Magid, fantastic presentation. I too value the connection between neighborhood and school. My dissertation many years ago was looking at a wonderful study that we did here in New York City, looking at the effects of 9/11 on New York City public school children. And I too looked at the influence of neighborhood versus the influence of school. And just as you have reported, there were several factors that neighborhood was more important, and yet some factors that school was more important. And as one, I would love to maybe collaborate with you on we just published a paper looking at neighborhood, but because of the way that the sample was collected and the weighting of it, it requires a little more thinking of how to better integrate the school environment into the neighborhood environment. So I would love to maybe collaborate with you on a paper looking at mental health related effects as opposed to tobacco and cancer, something else, if you're interested.
Thank you. Likewise, that sounds like fantastic work. And I can only imagine what the project would look like if you had longitudinal data to study the traumatic effects. Yeah.
We would too. Unfortunately, it was because of 9/11 and circumstances surrounding it, it was a cross-sectional study.
Mm-hmm.
Yeah. We do have many other studies related to 9/11 that are longitudinal, that we have much finer level neighborhood information that we can collaborate on something like that as well, if you're interested.
I'd love that. Yeah, I mean, I always think about how, unfortunately, there's a lot of times a trade-off between the level of aggregation and the availability of the years of data that we have. It's usually we usually have to pick, or are forced to pick, but the studies that have both are always wonderful. But
I hear you.
Yeah,
excellent talk.
I have a question. Hoda. Oh, Charlie, did you want to chime in?
Go ahead, and then I will.
Mine is a little bit bigger picture, if yours is more specific to okay. So my bigger picture question, Hoda, is, as you know, we here in Epi have a unit that has been a couple years ago, when Charlie came to the department, been constituted as an integration of, or a merger of, social epi and spatial epi. And it's really rare and exciting to have a scholar like you, who's actually formally trained in both of those domains and is integrating them. And I'd just be interested in your bigger picture thoughts about that integration and where you see them as being really profitably aligned or divergent, how you think of things like theory fitting into this. I mean, we do see that this is where a little bit more emphasis typically happens in social epi, but as Chris, who's here, knows and does himself in his own work and his own teaching, drawing on theoretical underpinnings of the disciplines that, like, geography behind spatial work as well. And just interested in your thoughts about that integration in research and in teaching.
I love that question. I could talk all day about that question. But briefly, in summary, I'll just share a quick experience that when I was at Cal and looking for resources for spatial epi, I actually had to go to Stanford to go to the Geospatial Center. Not that Cal doesn't have those resources, but Stanford had an official Geospatial Center that I could work in. And when I tell you I was the only person using that center for at the better part of a year, for the most part, like without exaggeration, for the most part. And it always felt so crazy to me that I had access to all of these resources and nobody else was using them. And it was primarily because people didn't know about it. And so I think this kind of occurs in two sections. That I completely agree with you that the social and the spatial cluster at Columbia is very unique and very exciting in that regard. I also think it's on us to make sure that students and trainees and staff and faculty are aware of those resources, because I think that they can serve so many different needs in our research and in our training. And then with regards to training, I think it's really important that they're integrated together and not in silos and vacuums that the way that they have traditionally been taught. So often spatial epi is taught from the perspective of physical determinants, built environment, risk assessment, right? And spatial epi is taught from fundamental ecological theory, fundamental causes, the socio-ecological model, and they're not often integrated within each other. And I think studies of urban public health or urban health in general really inform or provide a great opportunity for us to integrate both together. That is to say, I think both of them have to exist together and they can't exist alone.
Great. Charlie, you want to go in? Yeah, go ahead.
I really enjoyed your talk. Thanks for taking the time to come speak with us. And you're getting some great input from various of our spatial epidemiologists that have joined today. So, and I have to say, when I was at Cal, I experienced the same thing you did. And I had to go to the School of Forestry to get GIS support and work with people who knew what they were doing in that and learn from that. So it's very interesting. I guess one of the things I really thought was interesting about what you said is this. I think it was in a spatial epi context, focusing on the physical and social, I guess, parameters, or perhaps environments. And that's the first time I've seen someone really put that "and" in there. And so I was very struck by that. And I'm wondering, are there others who are having this same thought? And if so or not, what is it going to take to move people to begin to think about the intersection of those two concepts and parameters, I guess?
Thank you. I could also talk about that question all day long. Yeah, I've thought about this a lot because while some people have studied or looked at social determinants, and I mean, that's literally the definition of social determinants of health, is all of these taken together. It's just so interesting to me that so many studies don't use both determinants to examine disparities. And if they do, they don't use it in the same study at the same time. And so I think that that's not just related to a theoretical perspective of how we approach the social determinants of health, but also of just a data availability perspective. So for example, the availability of spatial epi tools to link data sources from physical data to social data. And so I think it's kind of a multi-pronged issue, but in general, no, I haven't seen people look at them and together at the same time. But it would be really great to move the needle in that direction. And I think spatial epi is a tool to do that.
Thanks. Interesting.
Chris?
Hi, I'm Chris Morrison. Thank you for this. It was a great talk, and this is a great discussion. Your responses prompted me to something I've been thinking about recently, which is that spatial epidemiology, or epidemiology, has over the last few decades has really sort of seeded the spatial realm, and it's sort of, there's statisticians and geographers have sort of wandered into that space and claimed that territory. What do you see as being the unique role that epidemiologists can play with spatial data, that the geographers and the statisticians and sociologists and criminologists and economists who all sort of work in that space now? What do you see as being our unique role in that space?
I think it's a really great opportunity for interdisciplinary research. I think we can learn from them, and they can learn from us. I think what we can contribute is theory like fundamental causes, like the social ecological model, like this idea of nested conceptualizations of place. I think that's probably our biggest contribution, in my opinion, is a very, very careful approach to how these are related to produce health.
Great, thank you.
May I?
Yes, Maurice, go ahead, please.
Okay, thanks. So I have a further question building on the question that was asked there. So in your model about hypertension disparities, you had the social, the spatial, and the, I put figure 2, the structural. I was curious, what you had race as a social construct separately. So separately, and then you had socioeconomic status, socioeconomic spatial, and part of that had race ethnicity also. So I guess there are two sub questions. It's like, do you think race itself as a social construct do you mean to me that it permeates so many things that you have to put it separately? And the second question is, but then it doesn't fully explain it by itself why you had to add it to the spatial that you have. And the second question is, do you think that it permeates to the point where gender is not part of the social construct? Because sometimes we can also put the two. I'm hoping that my question makes sense, because I don't have the figure in front of me anymore.
Yeah, so I think you're speaking about the arrow from race to the socioeconomic and the structural domains that I had for the K. Yeah. So so a couple of things there that probably in the hypertension literature, probably the most, especially because we see such distinct disparities between, for example, Black Americans and white Americans, or Black Americans and other racial ethnic minorities. The arrow between race as a social construct and what it represents is what I was trying to get out there. That has been repeatedly examined. And I don't mean race as biological, I don't mean race as race, I mean race as racism, and what that entails. And so that explains that arrow. And then for the inclusion of the very specific race ethnicity domain, that's been based on the prior literature of what traditionally SSP has looked like. And so I haven't started this project yet, and I'm kind of setting up to work on it now, but I agree with you that that arrow is probably the most complicated one within the conceptual framework.
Thank you.
Sorry. May I ask a follow-up question?
Yeah.
Great answers, but I'm getting excited, so I'm starting to think of it. So you talked a little bit about kind of the field and where it's going, and Kirsten's question was so excellent because I think people are increasingly recognizing the salience of context, and there's a lot of different groups, and how we think, inherently shapes how the questions we ask, our approach methodologically, blah, blah, blah. What are your kind of, and not necessarily your K, but where do you see your work going? It seems like it seems like you have a strong basis and you're interested in important things and you're thinking about the different issues in the field broadly. Where do you see yourself kind of going? Like, what are the big methodological and or substantive questions that you're hoping to ask and answer? And I know that's a lot in 3 minutes, and I have a meeting too. But I'm just curious to get some senses of like what's next for you, and not necessarily your K, although that's great. But maybe your first R1, or I don't know.
Yeah. Thank you. That's a great question. I've also thought about this a lot. I think, especially for health disparities research, there's been so much research identifying that social determinants of health at multiple levels are influence health disparities, right? And so big picture things, right? Like you said, beyond the K, maybe in an R1, I really want to move from this idea of what health disparities are, what social determinants of health are affecting health disparities, to how they are. And most importantly, I want to do that for the purpose of translation, for interventions. And so big picture, I'd love to really shift from these associations to interventions, and really examining what interventions work and how we can implement them for highest impact.
That's awesome, and I share that. That's what we're moving to as well, or at least my group. Cheers. Excellent.
Go ahead.
Hello.
Hello, hi. I really appreciate the clarity of your presentation, and you prepared very well, and you articulated the concepts and methods extremely clearly. So thank you very much. You got a lot of big picture questions. My question is much smaller and more on the epidemiological design front. In the second study, you presented the telemedicine utilization study. What are the controls? I just missed that part. How did you select the control?
Yeah. Oh, I actually didn't mention that part, so I'm happy you asked. It is a matched nested case control study. So those controls are matched based on geography, I think based on race and sex, sex and age and geography. Those are the three I can remember, and I think a couple of other things, but they are matched controls, and they're matched in a 1:5 ratio.
So just for my understanding, it's a nested case control design based on the instance density sampling strategy. And the controls were selected at random at the same time when the MS patient used telemedicine. Did I understand correctly?
Correct.
Because it seems the population is the VA users, right?
Correct. Yeah, the entire population were patients in VA healthcare. Mm-hmm.
Okay, Gerald, we're at time, right?
Yes, we are.
Okay. All right. Thank you for this fantastic presentation and really engaging discussion that ensued because of it, Hoda. And please, everyone, just join me in saying thank you and giving you a round of applause and appreciation. And really appreciate you taking the time to be here with us today.
Thanks for having me. Thank you so much.
Great way to start 2022.